All right, so I'm going to be talking about the medical management of small AAAs. So I want to start by just putting some definitions out there so we're all on the same page. What is an aneurysm? We probably all know, but the formal definition is when the diameter is 1.5 times normal. So aneurysms occur all over the body. For AAA, usually the definition we use is when absolute diameter is greater than 3 centimeters. And then small AAA are usually defined when they're between 5 to 5.5, or when they're less than 5 to 5.5 centimeters. And we'll kind of get to how we came up with that definition. And 95% of them are infrarenal, which makes treating them much easier, but then obviously the rest of the 5% become more complex. Over here is just an image of an infrarenal AAA. So the natural history of aneurysms, they grow about 2 to 3 millimeters per year. Current smoking is the strongest risk factor, and it doubles the risk of rupture. And then the rupture risk depends on the size. As the aneurysm grows in size, there's an increased wall stress, which creates potential for rupture. So here we have a chart here which shows that when the aneurysm is less than 5.5 centimeters, the annual rupture risk is less than 1%, so not very high. However, as the aneurysm gets larger in size, that risk drastically increases, whereas when you're above 7 centimeters, you're up to 32%. So when do we treat? Well, there's 4 landmark trials that help us guide when to do aneurysm repair. So the first 2, the UK small aneurysm trial and the ADAMS study, those were done about 20 years ago. And they looked at, they were randomized trials. They compared open repair to just surveillance when the aneurysm, and they found patients that had aneurysms that were between 4 and 5.4 centimeters. They followed these patients. If the patients got to 5.5 centimeters, then they crossed over and then the repair was performed. And then more recently, in the last 10 years, the CSER and pivotal trial were performed as EVAR became more popular. People felt, well, maybe if we treat them with endovascular repair, we can treat them at a smaller size. Well, so in these 2 trials, they randomized, again, patients with aneurysms that were between 4 and 5.4 centimeters to either surveillance or immediate repair with EVAR. So all 4 of these trials did not show a significant difference in mortality between if they treated them right away versus doing their surveillance. So based on these 4 trials, our recommendation is in general not to repair below 5 or 5.5 centimeters. So when to treat? As I said, these trials, which a lot of them were actually done in males. For instance, the ADAMS trial was performed in a VA system. So obviously there was basically no females in the trial at all. And that's where they came up with 5.5 centimeters. More recently, they've looked at rupture rates for women, and the consensus is heading towards repairing at 5 centimeters for women who obviously have a smaller aorta to begin with. Repair, however, is tailored to the patient. So we're always weighing the comorbidities and then the complexity. So for an infrarenal repair, the mortality and post-op day death is very low. Whereas if you have a thoracoabdominal aneurysm, such as here, we use a higher threshold, and we might be looking at repairing greater than 6 centimeters because we have to enter both the chest cavity and the retroperitoneal space to repair, or it's a complex endovascular repair where we don't have good grafts that aren't custom or aren't modified to repair. So what to do before we operate? So surveillance right now is the key. This is the guidelines from our vascular society of how we should surveil these patients. So between 3 and 3.9 centimeters, you surveil them every 3 years. As they get larger, you increase the frequency. Initially, we use ultrasound. So sending out the patients to our vascular lab where the techs are trained to look at aneurysms, and they're very good at doing that and can really define the anatomy accurately, is important for the first, as the aneurysm is small. As it gets larger, we consider doing a CTA or an MRA, where we then have information for operative planning, and then we can actually look at the anatomy and tell the exact size. What are other things that we can do before we operate? So medical management is, smoking cessation is the most important. On the right here, we have two graphs. These both show years of smoking and then this packs of cigarettes per day. You can see as you smoke more and for a longer period of time, your risk of having a AAA and the growth of that is significantly increased. The other interesting thing is that as you compare former smokers versus current, you can see there's also a difference. So it's really important to show this patient that if they stop smoking, that is really going to help them from the beginning. So there have been some small trials to look at other medical therapies, including beta blockers, ACE inhibitors, antibiotics. There have been some small retrospective studies that maybe will show that there's a signal towards decreasing aneurysm growth. However, then subsequent larger studies have disproven that. However, these medications, if they're indicated for the actual patient, for their other more comorbidities, have been demonstrated to be particularly helpful. So while not indicated for the actual aneurysm growth, it is still very helpful for the patient themselves. There are still many ongoing drug trials right now. There's trials to look at using antibiotics, injecting stem cells. So people are trying to find a lot of new novel ideas to slow the growth. However, there's nothing proven right now to arrest the growth of an aneurysm. So there are some special circumstances where we might consider repairing a smaller aneurysm. So certainly for a saccular aneurysm, where we don't have good data to suggest when we should repair them, that would be an indication for potentially repairing. However, we usually, depending on what the patient's comorbidities are, we might also surveil them and then get a sense over a year how rapidly it's growing. Rapid growth of AAA is another indication for repair. In general, for a normal aneurysm, we don't see it growing more than 3 or 4 millimeters per year. So if you saw an aneurysm suddenly grow 1 centimeter, you'd be concerned that that's something that we need to repair sooner. One caveat with that is that oftentimes, rather than the true aneurysm growing, we see a change in size when people switch from, let's say, ultrasound to CT, or going from a CT to an ultrasound. You might see rapid growth, but then when you're comparing the same modalities, the growth is what we'd actually be expecting. So you have to be a little, you have to look at that rapid growth with a grain of salt. However, in pathology such as dissection or patient with Marfan's or potential mycotic or infected aneurysm, then you could definitely see rapid growth. And of course, as we discussed, female patients where their native aorta would be expected to be smaller, we'd usually recommend at 5 centimeters. So in summary, there's no proven intervention to arrest the growth of aneurysms currently. Smoking is the most important modifiable risk factor. Surveillance with ultrasound and then subsequently CTA is preferred. And then we usually will repair aneurysms when they're greater than 5.5 centimeters in men or 5 centimeters in women. And of course, these are all, everything is tailored towards the patient. So if they're particularly anxious or we think there's an indication to repair it at a smaller size, then we take that at a case-by-case basis.